Good afternoon. Well, welcome everybody to PinPoint Plans webinar number 4. Today's topic is reference-based pricing, and we'll go ahead and get started now. For those of us who are joining us, again, thank you for coming back. And we've had a series of educational webinars talking about PinPoint plans and our revolutionary approach to health benefits. Today's topic is based on reference-based pricing, as I mentioned, and what that offers for a self-insured employer in their healthcare to reprice or renegotiate the price of healthcare or the cost of healthcare. We're going to get into how it works, what goes on behind the scenes and all the stuff. But before we get any further, we'd like our webinar today to be interactive and for everybody to participate. So down at the bottom of your screen, there's a Q&A or a chat function. You can use either way. Prefer that you use the Q&A and type in we'll bring up some questions. Go ahead and type in your questions or your responses to the surveys we're going to have throughout the webinar today. And question number 1 is, what have you heard about reference-based pricing in the past? Go ahead and use the Q&A function to write in what you may have heard or what your understanding is about reference-based pricing. Very good. We've got a couple streaming in now. So we've got one saying we haven't heard anything, another saying that it's a kind of a new way of doing business, and you know there's a lot of misconceptions about reference-based pricing out there in the marketplace. Some of them are based on experience to another way that things are done. Some of them are just hearsay, and we're going to go through all of it today. So PinPoint has adopted reference-based pricing as a foundation for the method in which we price claims. However, it has been an evolution in how we got to where we're at. And what you may have heard about reference-based pricing in the past, I want to assure you, is not the way PinPoint does business. A couple of things to go through. Again, write your questions down below. We want this to be interactive. It is being recorded, and we'll send out a replay to everybody who participated today, tomorrow. One of the things that we really want you to know, it's not too late to engage with PinPoint for your plans for 2021. Who you're going to be hearing from today, first and foremost, myself, Jeremy Price. I'm the Director of Business Development at Breakpoint. We are a part of the Acrisure Network, and we are the stop-loss provider for PinPoint plans. Lester Morales, who has been in benefits for well over 20 years and truly an expert in reference-based pricing for the last 4 years, doing this day in and day out across the country. We're excited to have him join us. And then Paul Carter, Chairman and CEO of HMA, the TPA associated with PinPoint plans. And they're really the foundation or the cornerstone of how PinPoint plans reference-based pricing works. A couple of things that we'd have you consider. If you hear nothing else, please remember this. Reference-based pricing does not have to be problematic. It truly can be a win for the employer, where you can save money by repricing claim cost. It can be a true win for the employee. They have coverage, options for great quality coverage and saving money themselves, and it's a phenomenal option for providers or facilities to get paid in full, quickly, in a manner in which they like to do business. And then number 3, moving from a traditional plan to a self-funded plan with reference-based pricing can be a lot of change, but that change can be a great opportunity to provide additional or competitive benefits to your employees, and we'll talk a little bit more about that later on. Next slide, if you don't mind. So let me introduce a little bit further Lester Morales. Lester has been in this space for quite some time, working with agencies and brokers and companies across the country, introducing the concept of reference-based pricing and spearheading a revolution with this repricing program to get it to where we've got it today. Lester is an expert and a thought leader across the country with this, and we're really thrilled, Lester, to have you with us today. Why don't you go ahead and get started and walk us through, the problems that are associated with healthcare today and why reference-based pricing can be such a valuable tool for an employer in today's environment.
Awesome, Jeremy, thanks. And good morning, I guess. It's probably afternoon for most people, so it's good afternoon here on the East Coast. So, again, Lester Morales, I'm unfortunately a very pathetic person. My degree's in risk management insurance. This is all I've ever done in my whole life. And this all stems from personal experiences I've had, unfortunately, with my parents. I've had both parents pass away from cancer, and walking through and understanding health insurance just became frustrating as growing up. My dad was diagnosed with multiple myeloma when I was 16 years old. My family had to file bankruptcy when we were 18. And then I got my degree in this and worked for Willis Towers Watson for 13 years. And I thought I was actually being part of the solution. But when you started seeing what we were doing to healthcare costs, I realized very quickly that, wait a second, this is a broken model. This is a slide that's showing the percentage of somebody's income that has been dedicated to healthcare costs. And let's just say, you don't have to read all of this, but blue is bad. And so as you see, as we've gone over time, and we need to find a new slide here, this is really showing the fact that the reality of it is all we've been doing as a cost containment feature year over year over year has been simply adding more cost to the employees and their family. And again, coming from a family that filed bankruptcy, I take this very much to heart. And so you start to realize, okay, well, wait a second. Why are we not figuring out how to solve healthcare costs? And I'm going to start with one thing that, again, it took me a long time to realize this, but the reality of it is what you as an employer call premium, your health insurance company calls revenue. Now, I want everybody to take an image of that, close your eyes and say, when you wake up in the morning, do you wake up in the morning wanting to increase your company's revenue or decrease your company's revenue? A little bit of a sarcastic question, obviously, but the reality of it is every health insurance company wakes up every day wanting to make more money. Well, Obamacare, as you'll see there outlined, established something called the MLR, the minimum loss ratio, which basically said health insurance companies are capitated on every dollar, how much of that dollar that they can make off of your good claims experience. So if they're capitated on saving you money, actually improving your claims, so they can't make a higher percentage, how do they save, or how do they make more money? Well, the only answer is to charge more dollars. And so it's a really interesting thing when you start thinking about the misalignment of incentives that happen every day in the health insurance business. So when the carriers sit in front of you, and this might be another audience participation. So again, get your fingers ready to type into the Q&A feature. If you've ever had a carrier sitting in front of you, or if there's some advisors on this phone, and the carriers tend to brag about two main things. What things do carriers brag about when they're sitting in front of you? And I'm going to give it a second. Yep. So somebody had wrote in their network. So yes, the size of their network they brag about. And something else. Yep. Okay. The network discount. And so the interesting part that I want to take and chat about today is when your carrier sits in front of you and says, we have the best discounts in the market, whatever city, state you're in. I've never really thought about this until about 5-6 years ago, but discount off of what? So I liken this to, you walk into insert store. I'm going to go with Macy's. You walk into Macy's, you're looking around for a shirt. You find a shirt and you see up on the rafters there, they've got a 60% off everything. Well, the difference between what we do when we shop for everything else versus what we do when we shop for healthcare is, one, we don't shop for healthcare. Nobody ever asks any questions there. But two, the reality of it is we know the starting point. So if it says 60% off, I can look at the tag of that shirt and understand 60% off of what? Think about the last time that you've accessed healthcare. The cost of an MRI, how much is it? Has anybody told you? Well, when Blue Cross, when Aetna, when Cigna, when whoever says they get a discount off of it, they get a 50% discount, they're really getting a 50% discount off of something that's been overinflated. And so let me walk you through this slide. This slide is showing the difference between what a hospital gets reimbursed by Medicare and what that same hospital gets reimbursed, or what that same hospital bills at. So I want you to think the last time you went to the hospital, you got your bill and you see the obnoxious expensive price, right? A Tylenol got billed at $9, a cotton swab for $6, and you see the total cost of your knee surgery was $90,000 in billed charges. Well, that's the billed charge. Then you see the allowed charge, and that's after the discount. So let's just say it was a 50% discount, so that $90,000 now becomes $45,000. But the reality behind that $45,000 is that's probably still 3 to 4 times what Medicare reimburses for that same hospital. This interesting slide will show you these are 197 hospitals that we looked at if you were having an appendectomy. All right, something super simple. What I want you to take from this slide is, one, look at the variance between all of the different hospitals and what their bill rate is. The difference between what those hospitals are billing at and what they take from Medicare is, you'll see to the left-hand side on that box, almost 600% of a difference. So when Blue Cross sits in front of you and says, oh, we get a 50% discount, they get a 50% discount on something that's overinflated almost 600%. Therefore, you're still paying nearly 300% of Medicare. This is a RAND study that just came out literally last month that shows, on average, across the country, the health plans are typically paying almost 250% of what Medicare would pay. Now, the reason we keep talking about Medicare is because Medicare uses actual cost data from the hospitals to determine how much they are going to reimburse that hospital for the services that Medicare patients actually take. Nearly 60% of the healthcare dollars spent in the United States today are reimbursed by Medicare. And almost 7% of hospitals take Medicare. So the reality of it is, every single day, somebody, one of your members, their employees and their families, are walking into a hospital. They are having a service and they're paying almost 250% more than what that same hospital for that Medicare patient that was sitting next to them in the waiting room actually received. And so the question that we have is that fair? Is that reasonable? And Does it work when you do it a different way? And so this is a slide that is showing a busy slide, but what I want you to take is this is 99.6% of the time, we are able to get a same hospital to take 164% of Medicare. That is attributing almost a 25% savings for you as the employer. And the carrot that we use for your employees to get them to work with an advocate to understand all of this is we waive their deductible and coinsurance. So I just published an article the other day that was talking about some stats that a hospital typically spends 3 to 4 times as much money collecting a dollar from a patient as they do the payer. So you, if you're self-funded, are a payer, or the health insurance company if you're fully insured. So the reality of it is being able to work with a hospital and telling them that they don't have to chase any dollars, meaning they don't have to have an accounts receivable, they don't have to collect any money from your employees, is actually a negotiation leverage because it costs them so much to collect those dollars. And so when we look at this, we're like, okay, wait a second, this sounds too good to be true. I could save money. My employees aren't paying anything. I don't get it. Who else is doing this? One, hospitals do this for their own plan. If you've ever known somebody that works for a hospital or seen a hospital's plan incentivizes their employees to use their own hospitals for their own services. And it says, if you go somewhere else, the plan is going to pay a little bit less. Very similar to what we do when we buy a car or whatever. When we go here, the price is X. When we go here, the price is Y. The entire state of Montana is on a reference-based pricing program. They have led the pack in the public entity space, and they have worked out and basically said, hey, the second largest P&L expense item for our entire state is the benefits program that we offer to state employees. We can do so much with that extra money if we just had a better health plan offering. And so they moved their entire state program to a reference-based pricing. And all of you who have an out-of-network benefit in your plan today, utilize a form of reference-based pricing. Today, you probably are familiar with a word called usual and customary. Usual and customary is a form of reference-based pricing. And so all I want you to do if you left my section with anything is, one, the current system is broken and it's not built to fix it. That's one. Two, you're already doing a form of reference-based pricing for your out-of-network claims, and I want to leave you with a definition. If you're trying to grasp your head around what it is that we're speaking about, the definition, what I like to work with employers and their advisors on the definition of reference-based pricing is doing nothing more than changing the way the health plan reimburses for services. If you think about how it happens today, you utilize your Blue Cross, your United, your Cigna, your Aetna, what we call the BUCAs, Blue Cross, United, Cigna, Aetna, Humana. They negotiate your fees for you, right? So you've never had a conversation that says, well, what does Humana reimburse that hospital down the street for a knee surgery? They won't tell you. All they tell you is that we get a 50% discount. Well, as I've showed you, a 50% discount off of what? And so, but if you think about the concept of a network, of a PPO, it is taking a billed charge and adding a discount to it, or what we call a top-down approach. But it's trying to come up with how much that plan is going to reimburse for services that are being provided. In the reference-based pricing space, all we're doing is the same thing. Instead of using a billed charge and working our way down, we use Medicare and work our way up. So as you saw, our average is 162% of Medicare versus the average health plan paying at $250 roughly. So we start with Medicare and work our way up, but trying to get to the same thing, which is how much does the plan have to reimburse for the services that are being provided? So that's a very simple way of looking at it, but it's all about the model in which you administer your plan. So I am happy to introduce Paul Carter. Paul is a great partner of ours. And in the PinPoint plan, the nucleus of the program is the program and the model in which his company HMA administers. So Paul, if you don't mind, walk us through the reference-based pricing 101, what it means, how the models look, and really get everybody on a level set here.
Okay, well, thank you for that. Nice to meet everyone virtually, and hopefully you'll find this informative. Go ahead, Lester. So Lester's already touched on some obviously critical components about reference-based pricing and how and what the value proposition is for reference-based pricing. You know, at its core, it is that cost up versus a known cost up versus an unknown charge down, discount off bill charge. And that's what everybody will spend a lot of time talking about. I kind of take it down. I'm a little bit more granular in my definition of reference-based, value-based pricing. Without a doubt, the known cost up approach, that's the mechanism. But the real leverage, the real power of reference-based pricing is contained solely and simply in the fact that we know what the price of the service is going to be before that service is rendered. Let's let that sink in a little bit. I want you to think about in your professional and your personal lives, how many purchases do you make? Goods, services, what have you. How many times do you buy something that you don't at least have some sort of an idea about what the cost is before you consummate that transaction? I would venture to say that there's only one in the vast majority of all of our lives, and that is facility-based medical services. And guess who facilitates that model? The hospitals themselves and the BUCAs. And make no mistake about this, they work in collusion. They are in total concert in keeping the actual cost of that service blind to the consumers. And I got to tell you something, I'm too old to go out and have any belief that I'm going to change this healthcare delivery model. I'm just going to, you know, change how everything works. But I am on a mission to absolute correct that absolute deficiency in the model. It is amazing how much pressure, how much leverage is gained by the purchaser, both the employer group and the consumer, the member, when you are forced to talk about the financial aspect before that service is rendered. A couple other key points under this model. The second bullet there, talking about quality and the value of the healthcare services. Quite frankly, it's one of the things that frustrates me about our model and the people that we compete against. Because obviously, when we're out there talking about how the PinPoint plan works and how everything is cohesive and working towards to get the member in the highest quality, highest cost value provider out there, we have to answer to that. We've had to build systems and processes to make sure that happens. But the frustrating point is our competitors have not. You know who never gets asked about what provider I should go to? Blue Cross. And if they did get asked, they can't answer it because Blue Cross is contractually not allowed to steer a patient from one of their contracted facilities to another contracted facility. And I want you guys to think about it wherever your home area is, wherever you are located and you have employees. I want you to think about, draw a circle, maybe a 50 or 75-mile circle from where you're at, and how many hospitals or ambulatory surgical or ambulatory diagnostic centers are in your area. And then I want you to think about how many of those are contracted with the local Blue Cross plan, United Healthcare, Cigna, Aetna, or Humana. We collectively refer to them affectionately as the BUCA. Chances are the vast majority of them are contracted, and so the same people that we're going to be referring and we're going to be negotiating on your behalf and your employees' behalf to save money are the same people that are going to be servicing you and your family members under a Blue Cross plan. We have to show, and we do it gladly, how that cost and quality fits together. They simply do not do that. And then obviously price transparency, it creates an informed consumer. The best way that I can explain what the program works is I'll give you a real life example. I'm doing a best and final presentation with a large employer group. And as I got done, I was handed a letter that was sent to this group from a hospital system. And the hospital system said, I understand that you're looking at a reference-based pricing program. I wanted to let you know we will not participate under this type of program. And the analogy that the hospital used was, if you owned a car lot, you would not allow a consumer to come on your car lot. You give them the keys to the car, and then they tell you 45 days later what they're going to pay for it. Sincerely, hospital CEO. I read the letter and they said, what do you think? And I said, I agree 1000%, absolutely agree. And they said, well, doesn't that blow up your model? I said, not exactly, because you're missing the other side of the equation. The other side of the equation says, if you are a consumer, you are not going to walk on a car lot, sign your life away, they hand you the keys, and then 45 days later, they tell you you owe them $300,000 for a car that you know you could have bought for $30,000. You guys, that is simply what we are addressing at its core to drive these savings while we increase the quality aspect of the healthcare that's received by the members. We want them to know what that service is going to cost before it's rendered. The benefits of it are enormous. The stop loss, I mean, categorically, without a doubt, these programs will save your company a lot of money. Every single client we win, we only win because we've been invited to the party. We're only invited to the party because we put a significant cost savings in front of them. No one leaves Blue Cross for a neutral rate impact. So these programs categorically will save money. They categorically will save your employees money because now they're able to be rewarded when they're better purchasers of healthcare, and it just changes the entire dynamic from continuing to absorb the cost increase and/or passing the cost increase onto the employees in the form of higher out-of-pocket expenditures when they actually get the service, or higher employer or employee contributions out of their paycheck to pay for it. So there's really three different models. Okay, the first one, we'd like to call it gotcha or scorched earth. This is sort of the granddaddy of it all. That's been around for about 12, 14 years. Any of you guys that have had any exposure or knowledge to these types of programs and that you've heard negative comments about it, most likely the vast majority of time it's going to tie one way or another to this model. It is really a bad model. It places the members absolutely in harm's way. It is very limited to no pre-service advocacy. So all of the benefits of everything that I have just said go out the window on this model. That letter from the hospital system is aimed at that model. We're not going to do pre-service advocacy. We're not going to have an agreement before the service is rendered. and we're going to roll the dice on behalf of your members after the service is rendered. Not a fan of this model, and I wanted to point out that it's a non-integrated model, so you have multiple different service providers, companies, trying to service you and your family members. The second model is where everybody else is, and we call it the inform but not engage model. Absolutely a far superior model than the first one. You are now bringing in aspects of the pre-service advocacy. You are informing the providers what they're going to get paid, but you are not engaging with them to get that signed single case letter of agreement in hand. That is a fundamental difference between the PinPoint plan and every other plan. For every single service that the PinPoint plans operate, the reference-based pricing model, which is going to be your high-cost diagnostics, your facilities, dialysis. I mean, these are the things that cost 80% of your health plan. We will seek and obtain single case letters of agreement for every single non-emergent case before the service is rendered. Under this model, they do not get that agreement. And I will point out, once again, it's a non-integrated model, so you have multiple companies providing the service. The PinPoint model is the sole source model out there in the market. It is the only one that brings the fully integrated services, all of the services from the clinical management, the claims adjudication, customer service, the advocacy. Everything is done under the four corners of the same company. It also is the only plan that has its own wholly owned, maintained, and developed provider network, a provider network that allows for it to have a customized network solution for every group, regardless of size. And last but not least, it is the only program that does the pre-service advocacy and gets that single case letter of agreement in hand before any non-emergent service is rendered. You put this stuff together, I can tell you that the stop-loss markets absolutely love this model because they get all of the benefits of the cost savings without these cases sitting out there open forever and ever. And so it is a great model and one I think you really should consider. So this is the foundation of how the plan works. You've heard the term evolution. I'm a big believer in evolution, and this is a central part of that evolving of the healthcare delivery system. And basically, all this slide is saying is, we're going to take 80% of your encounters, 80% of the services that you and your family members use, and you're going to not have to make any changes on that. And this is your physicians, your labs, your home health, what have you. And you're going to get that network. You're going to make sure your kid's pediatrician is in network. Make sure your family doc is in network. Same things that you're used to. But those 80% of the services only account for 20% of the cost. That allows us to go out and say, okay, before you go and receive these higher cost services in a non-emergent manner, pick up the phone, work with your advocate, and life is good. So you're talking about 20% of the services, but those 20% equate to 80% of the cost. This is where we make our do our magic. This is where the savings are driven for both the employer and the employee. Multiple tools in the toolbox here. Direct purchasing, direct contracting. That's the ability to have that customized provider network. You and your employees have control under this model on who you would like to see in your network, what clinics you would like, what local labs you would like. These are power. This is leverage and abilities you simply do not have with a BUCA plan. They really don't care. It's their network. Reference-based pricing we've talked a bunch about. A bundle payment, absolutely a huge part of the program. We have direct access to literally thousands of ambulatory surgical and diagnostic centers, as well as tertiary care centers, for inpatient services, and these are all contracted with a single price that includes everything. So how many of you guys have had the infamous out-of-network anesthesiology balance bill, or the pathologist, those kinds of things? These types of programs not only save a fortune, but they absolutely eliminate that because it is an all-in single price. We call that a bundle payment. And then last but not least, every plan that we do, certainly the PinPoint plan also, and any plan that you guys administer for your own employees, has to have the ability to reward members when they become better purchasers of healthcare. And these programs are built with the ability to significantly decrease, if not eliminate, the out-of-pocket expense for the members when they actually receive healthcare services. And the patient experience is, quite frankly, no different than what they're used to right now. The sole exception to this is in the event that PinPoint plans philosophy on those inpatient services is to always get the member into the originally requested provider. We are successful 75% of the time. That means that that patient experience is absolutely no different than what they're used to, other than they don't have to pay their deductible. However, 25% of the time, we are going to work, our advocates are going to work to get that member into a more appropriate setting. Like, no one should ever go to a hospital to get a CT scan, because you are going to pay 5 times more for that CT scan than what you can buy at an ambulatory diagnostic center. Or if that originally requested hospital simply will not negotiate an acceptable reimbursement under the plan. In other words, they're saying, we'll give you a 10% discount and our cost to charge ratio is 800%. Well, that's unacceptable. And our advocates will work to find alternatives and then work with that member and their family to get them into those higher quality, lower cost providers. And in the event the member says, nope, I'm still going to that originally referred provider, they can do that, but they do so knowing what the financial repercussions are before that service is rendered.
Great, Paul. That was a fantastic walkthrough of HMA and how PinPoint plans functions on the repricing model and for a member. We do have a question that has come up, and I'll throw this out to either you or Lester to answer. The question is, how do I know if PinPoint plans and reference-based pricing will work in my area?
So Paul, I'll take in, you could add anything. So, quite honestly, guys, this is nothing different than asking, will a hospital take cash? I mean, we're essentially saying, hey, we're going to pay people differently. We're going to pay them faster. We're going to pay them where they have less confusion. And so a majority, and I'm talking 95% of the marketplaces out there, this works like a dream. There are a couple of hospitals that have been, a little less than reasonable. And those are the same hospitals you see having lawsuits brought against them and having to pay hundreds and hundreds of millions of dollars in their mischievous billing practices. So, Jeremy, we have had success, clients in 30-something states, members in mostly all states. And so I'm not going to say that this is, equally as potent in every market, but it's absolutely viable if, and I think Paul did a great job in explaining it, as long as a client realizes that the cost and quality of healthcare is different in every single market, in every single hospital. And right now, we are doing nothing to help the member actually shop that, understand it, any of it. If they understand that, then the reality of it is this plan is a dream, because not only are we going to help members get to the highest quality, because again, ask yourself this: if it was your loved one, if it was your dad that was going through multiple myeloma and having a bone marrow transplant, wouldn't you want access to hospitals no matter what market you sit in? Wouldn't you want a network of best in class centers of excellence? Everybody look at what Walmart's doing. Look at what Amazon is doing. These employers have realized and figured out that, one, healthcare is not just delivered right in my backyard. And two, even if it is, it doesn't mean that it's the best. And for, 85, 90% of your costs, which are non-emergent claims, people are scheduling an appointment for that surgery. And if there's a better being defined either in the cost or the quality conversation, how do we get them there? I mean, that's simply the answer, Jeremy. So I think most markets are ready to go, and it just takes the employers and their advisors who consider themselves to be innovative and the first movers, because you heard it here first, folks. There is zero way that healthcare is going to get more PPO and less transparency. We are just ahead of the time and ahead of the transparency, and you'll see it in the conversations that are happening in Washington around prescription drugs. You're going to see it more and more with hospitals wanting to have direct relationships with employers. We have to force a change, and it starts with transparency.
Fantastic. Thanks, Lester.
Jeremy, I've got a question for you, because this is interesting. Breakpoint is a stop loss market. So you guys are the actual insurance company behind this program. So you see it from the claims and the impact that it's having on the claims, but you guys also eat what you cook. And so you, as your, I believe, 115 or so, or somewhere right around there, employees there at Breakpoint in Las Vegas, Nevada, are on this type of plan yourself. So let me ask you the question, one, from the risk side, does this actually save people money? And then two, you actually are a plan participant. How have you experienced accessing healthcare in this type of plan?
Great couple of questions. So from an insurer standpoint, when a member who is insured goes out with us and goes out and gets, let's call it one of these surgeries, maybe they need a hip replacement, and just to use round numbers, let's say that the bill charge for that hip replacement is $100,000. Using Paul's team and the repricing method of reference-based pricing, where we're typically going to end up is about a $22,000 allowed charge, or a negotiated price of about $22,000, or a 77 to 70%, 78% savings from billed charges. As an insurer, that allows us to reduce the cost of insurance inside these plans, right? Reducing the overall spend of an employer. We also can reduce what are going to be expected claims costs in the plan, therefore further reducing premiums. So the employer, we as the insurer love it because it is an actual reduction of claims costs. Employers love it because it's an actual reduction of cash flow or spend in one of the, usually for an employer, one of their highest line items for their business. As an employer, it's a different subject, right? We want to take care of our employees. We want to make sure our employees have the access to the best health care. And we've been through a similar evolution. PinPoint Plans has come together in part with HMA and Lester Next Impact, because we've been searching for a quality solution for our employees. Reference-based pricing done among the other models 1 and 2, will save money, but at the cost of the member or the employee. It's very disruptive to the employee. We have transitioned or evolved to the PinPoint model ourselves because we have found it is absolutely the best model for our employees. They get great quality care. They have an advocate that they can reach out to. Consider it a concierge model service, right? The advocates are fantastic. They know what they're doing, and we get tremendous customer service. In addition to that, our employees getting that service, our CFO loves this because we're saving tremendous amount of money on our overall spend for healthcare. So it's the best of both worlds, and we're thrilled to be a part of PinPoint Plans, not only as an insurer, but as an employer providing it to our employees.
Jeremy, I happen to know about a specific episode, but maybe you have something else. But walk us through a real life example. I mean, obviously, I'm not asking for any PHI, but you've got coworkers that are walking around the office bragging about getting a free surgery here, a free surgery there. Walk us through a real life example.
Yeah. So in my own department. One of the gals that works with me has recently been through the last 4 or 5 months has been through some issues, seen a lot of physicians, been to the hospital a couple of times, both from an emergency standpoint and a scheduling standpoint, and she was skeptical. We've been through a lot of different stuff over the years here at Breakpoint, experimenting with how to solve the healthcare equation. So she's been a little skeptical, I got to tell you the truth. She came to me at the beginning of this and said, I'm going to watch, I'm going to see how this goes. And a couple of weeks ago came up with her own write-up on how everything went. She has been flabbergasted, one, with the quality of service, and two, as she's looked at her EOBs, her explanation of benefits, in the savings that she's seen take place in this case. So she's been thrilled with the customer service, and then just frankly astonished at the amount of money that the plan has saved her. She's skeptical by nature. For her to come forward and say, hey, I love this and love the people that I work with at HMA is really a testament to what they do over there.
That's awesome. That's awesome. So I wanted to steal the floor and put a call to action. So I do these types of talks everywhere across the country. And the frustrating part is every single year, every employer, every advisor says, oh my gosh, I hate healthcare costs. And then yet we continue to do the same thing. So I wanted to make sure we talked about a couple of, live examples here. But the reality of it is the savings is huge. And so let's look at this across the entire PinPoint block of business. So this is a lot of numbers, but what you should see is the average person coming and getting a proposal was spending about $8,000 per employee per year. Their average renewal was somewhere just south of $9,200. Their average cost with PinPoint at the worst case scenario was $7,000, or nearly $1,000 off of their current cost, but over $2,000 versus their renewal. So when we look at that on a percentage basis, if we're looking at it versus current cost, we're looking at anywhere between 10 and 20%. But when we look at it off of the renewal, we're averaging between 25 and 30% off of your renewal. So I have to challenge every employer out there to just take a question and says, one of the things that we keep hearing this year because of COVID is we don't want to disrupt the apple cart. Our employees have been through so much change. But then in the same breath, that same employer is typically passing on a 5, a 10, a 15% increase on healthcare costs for that employee. Well, I've seen stats that inflation's obviously a couple of points. the raises are a couple of points. So the reality of it is, even with a raise of a couple of points, between inflation and their cost of healthcare, employees are actually taking home less money. And so when we start thinking about the word change, is the change better or worse to keep doing the same old thing? So one of the things that we've done with Breakpoint and the AccuSure network across the country is, if you're an employer and you are interested in a impact analysis, this is a no obligation. You are not obligated to buy anything. Actually, you can't even buy anything. The reality of it is, it's going to show you where your money could be saved versus not. So we have done this, and this is an actual live one on the screen right now for an employer that was about 150 or so employees. So, you know, a very run-of-the-mill employee or employer. Long story short, they're nearly $300,000 in savings. But when you look at this compounded year over year, they're saving a significant amount. So again, it is not too late, as Jeremy stated in the beginning of this, to be able to impact your January 1st renewal. So if you're interested, please either hit yes on this polling question, or if you didn't want to hit yes right now, the person who invited you to this webinar would be more than happy to run you through the process. This takes a very limited amount of data and can show you the roadmap of how you could save money. So again, Jeremy, I just wanted to make sure that we gave this opportunity for folks, but why don't you walk us through the next steps in regards to the webinar series?
You bet. So in this series of educational webinars for employers, next month in November, we will be talking about, we'll be going to the next level. So we talked about value-based pricing today, reference-based pricing, and then we have other methods that we use to contain the cost of claims. Primarily, one of those is going direct or direct contracting with hospitals in any given area, and what the advantage to you and your employees can be with that. We would encourage you to save the date, come and learn a little bit more about healthcare, how healthcare can work for you, not just paying your premiums and hoping that it's working for you and your employees. We'll be sending out emails for registration and participating in that. It'll be a great opportunity to learn a little bit more. For anybody that would like a quote request, please reach out to the advisor that invited you to the webinar today, and we would be happy to work with you and your advisor and get you a quote request and an impact analysis. It looked like we had a pretty good response in the positive to your poll, Lester, and look forward to fielding these for everybody joining us today. That's it for us. We thank everybody for taking some time out of your afternoon to learn a little bit more. There's a lot of work to do in our healthcare industry. PinPoint Plans is at absolutely the forefront. We're cutting edge methodologies and technology to help you as an employer save money, to help you as an employer provide better benefits and cost savings for your employees, and to help you as an advisor have an advantage in providing your clients best-in-class services. Thanks for attending, and we'll have emails out to you tomorrow with a replay, and we hope to see you at the next webinar.